how did you get here?
I was born here on this floor, around the corner. And I went away to high school at St. Andrews and college, and then came back and did some time post-college locally, trying to figure out what I wanted to do, and volunteered with the rescue squad here, and then became interested in medicine and ended up becoming a paramedic and firefighter with Anne Arundel County. So then once I did that for a few years, and then I really loved the paramedic program, which got me interested in medicine again. And then I went to medical school in Vermont, and then from there did some time in the Navy, and then finally got out of the Navy and did my residency at West Virginia University, and then ended up coming back here. I actually worked down at Easton starting in 2000 for a few years, and then an opportunity came up to come up here and help get the ER up to par, and so that's how it happened. Rural emergency medicine is very different. We don't have, it's not the knife and gun club that you'd see in an urban center, but you know, we still have trauma. It may be something like a tractor rolls over on somebody, or somebody gets trampled by a cow. You know, so there's still trauma, but it's very different mechanisms. And you know, you see much of the same stuff, much of the same medical cases. We have an older population here, so we see a lot of basic diseases, diabetes, heart disease, things like that. And then I think the drug abuse and that type of thing is very similar to what's in the city. Probably not on as big a scale, but we do have the same type of cases. There's a lot of prescription drug abuse in this area, and because of that, and it's, the heroin you hear a lot about, we do see that. We have had some major cases and some major overdoses, but I think it's all kind of related to the abuse of the prescription drugs, and they can't get that. Heroin is fairly cheap, and then folks move into the heroin. So it's a problem. You wouldn't expect it in this rural area, and you don't see it, but it is there, and there's a lot of narcotic abuse. You see it, in the younger crowd, certainly, but I've seen, 50, 60-year-olds that have overdosed or addicted to narcotics. So it's not, it's all different age groups. It's probably in all classes as well. It's certainly the same town. When I was here as a kid, you don't see the things that we see now as professionals in the emergency department. So it's kind of like out of sight, out of mind. It's just not something you would be aware of as somebody growing up here. So it is, in some respects, it's kind of sad when you see a lot of the ills of society in your hometown, which you didn't know existed. Yeah. But they do exist, and they exist everywhere. And then there's a lot of great things. I mean, the patients here are wonderful patients, very nice, very thankful, very appreciative, and it's rewarding to me to be able to, it's rewarding and it's scary at the same time, to be able to take care of people I've known all my life, friends of the family, friends of my parents, and it's nice, it's rewarding to be able to be here for them when they need you. But it's also sad if, people pass away and you see them aging, and that's very difficult. You have to compartmentalize, because even though, it may be your father's best friend that rolls in, or your neighbor that you've got to take care of, and it's emotional, but you have to put that aside, and you just have to deal with it and do your job. And it's not just the physicians. I mean, all these nurses live and work in this community, so they see the same things, and it's challenging, and it's rewarding at the same time. We are the safety net for the community, but I don't think it's just a poor person's issue. We do certainly see patients that are uninsured, but we see patients that are well insured, that do have money, that in some respects abuse the emergency department as well. It's gotten to be a matter of convenience for people. We, just like many other emergency departments, there's other people that do have family physicians, and for whatever reason it's not convenient for them, or they can't get into their doctor, so they would come into the emergency department. And we see it quite routinely. There's many, many things that are there on a daily basis that probably shouldn't come in, but we're there, we deal with it, and try to educate people as best you can, and hopefully they'll make better choices next time. I think for this department, the biggest things that we see are chronic diseases in the elderly population, because we have a huge retirement population. So it's diabetes, heart disease, lung disease. That's the overwhelming majority of what we see. I think the second biggest issue in my mind is the narcotic seeking behavior, the narcotic abuse. The alcohol is here and there. I mean, you do see it in the college, but I don't think it's any more than any other college. I think the narcotic abuse is throughout the community, and I think it is a community problem. It's challenging because the resources aren't necessarily there to be able to get people into rehab, patients that are insured or uninsured. There's limited places that they can go. Trying to get them to realize that there really is a problem is huge, because they're not yet ready to get help, but they don't recognize that it's a problem. I think physicians are kind of stuck because patients come to them for pain-related problems and they expect pain medicine, and we've been educated and taught that we have to treat pain. It's very important. You got to treat pain. So the pendulum has now swung, and we're treating a lot of pain, but then we're creating a lot of problems. So I think it's a system issue nationwide with medicine that we need to start addressing. It's not unique to here at all. So I've been here for 10 years now. I know pretty much what the capabilities of our physicians and the hospital are. Certainly major trauma would be flown to the trauma center, because the literature and the research all supports that it's best treated in a trauma center. Those type of things would go out. Somebody that's had an acute heart attack, where the literature supports emergent cath lab and opening up the artery, those folks would be flown out. We can give the clot busting medicine here if we need to, if we're down for weather or whatever. The goal is to have the artery open in 90 minutes. So we either expedite a helicopter ride, to the university or Christiana or Washington Hospital Center, or we can do the clot busting medicine and send them by ambulance. So those are two of the big things. Any neurosurgical emergency, like a hemorrhagic stroke, would be sent out. We don't have neurosurgery here. If it is an acute embolic stroke or clot stroke, that's in the window for the clot busting medicine, that has to be within 3 hours of onset of symptoms. Those we could certainly give the clot busting medicine, and then they would be sent to a stroke center where there's a neurologist. We don't have neurology here. We don't have obstetrics, so anybody that's in labor or possibly in labor, they would be sent. Pediatrics, on occasion, that need to be admitted would be sent out, because we don't have peds here, but it's really not that many that have to be admitted. Most of them can be, kind of tuned up in the ED and discharged. So I think those are the biggies. I personally like being challenged, and I like the critical care. So I like the critical cases. The other day we had 3 patients all at the same time. One was a preterm labor, one was a hemorrhagic stroke, and one was a woman in respiratory distress. So trying to balance all of that at the same time while you've got other stuff coming in the front door is the fun part about it.